Hello everyone, ladies and gentlemen, a hearty welcome to you all for this final session of the day of Virtual Implant-Expo 2020. So, Namaste, Joel Gonzales sir.
This is nice to
From
see.
Yeah, I'm Dr. Ashwin from Bengaluru, signing in here as moderator for this session. So, in this session, I'm privileged to welcome and introduce our very distinguished speaker from United States of America, that is Mr. Joel Gonzales. Joel Gonzales has over 30 years of extensive clinical experience ranging from the restorative and surgical aspect of implant dentistry to the laboratory aspect. He started his career as United States Air Force dental assistant specialist, working specifically for base periodontist and prosthodontist respectively. He was active in the duty and honorably discharged as veteran of foreign war after 4 years in the military. After the military, he worked as registered dental assistant and treatment coordinator for Dr. Peter Hall, a world-renowned prosthodontist and implant surgeon. During his 7 period of Newport Beach experiences in the Newport Beach, California. During his work experiences, he emphasized on full mouth reconstruction in conjunction with all facets of implant placements, appropriate restorations, laboratory procedures, as well as adjunctive bone grafting, tissue grafts, sinus lifts necessary, and all those procedures that were required to achieve optimal results for the patients. So, Sir has a very elaborative career, continuing with his achievements and further aspects. After completing his preclinical curriculum, he then changed the course under advertisement and attained his business degree. He entered the dental implant sales arena also as well. As in depth product specialist, he has always integrated his clinical knowledge and passion for implant dentistry in servicing accounts with in-office clinical support. His intricate knowledge and experiences with having worked with many different implant systems on the market, he contributed largely to the valuable support he is able to provide. For the past 10 years, Joel has also been facilitating live surgical courses and continuing dental education events for doctors internationally as well as in the US. His passion for education propelled him to found Implant No in 2013, which is an educational company providing free tutorial clinical content through the company website and social media. We are glad to have you in this session, sir, and it's a proud moment for us to have you here and also to say to our participants that in January 2020, Sir Joel was honored to become Megagen's Vice President for Western USA and Latin America. Sir, it's really a proud thing to have you us on this virtual Implant Expo 2020. So with this introduction on his elaborative career, I am proud to present Dr. Joel to the participants. Sir, the session is over to you. You may please proceed with your presentation. Thank you.
Thank you, Dr. Ashwin. It's definitely an honor to be here. Let me share screen here.
Yes, sir.
All right. Okay. All right. Can you hear me okay? Can you hear me okay?
Yes, sir. Yes, sir.
All right, here we go. Well, thank you for that introduction. I really, really appreciate it. And I'm actually very, very honored to be here. Thank you, thank you, thank you for the invitation. When I was coming up with the title of the presentation, I was sitting there going, what am I going to talk about? Right? So I'm sitting there saying, well, what about the biologic driven osteotomy? Really, most people are going, what does that mean? I have the advantage of seeing lots of different cases from lots of different dentists every day. So I get to see really a lot of mistakes being made, unfortunately. So one of the things I want to talk about are really fundamentals about how and why, when, and where. But without further ado, I really have to stop and take a moment to really thank my mentors and what I call my dental heroes, the people I look up to, Dr. Quang Bum Park, Dr. Howie Gluckman, Dr. Asha Suwaya, and as well as special thanks to Dr. Isaac Towell. Without their support, the videos especially would not have been possible. But I really want to stop and I always, whenever I do a presentation, I always stop and thank my life, what I call my lifetime mentor, Dr. Peter Worley, as well as Don Cornell. I worked for Dr. Worley, and he was very, very influential in my career and my development. And I took his advice and switched and got into the business world, and things have really, for me anyway, I love what I do because I get to interact with so many different dentists from around the world. And one of the things that I get to do is travel around the world and execute live surgical courses. It's really an honor and a privilege to do so. This one you see with Dr. Michael Worley and Dr. Ashra Suaya in Puebla, Mexico. But I always come back to the basics when we're talking about training and doing our particular procedures. I always go, well, why do we do what we do? All right. And, you know, a nice picture of a family. And the very first thing that our mind goes to automatically is the smile. We immediately go to the smile. But we see here, right, he's missing an eyebrow. But we naturally go to the teeth. This is just, I really think it's just the psychology of the human beings. We naturally go to the smile. So I'd really like to focus on three things in my presentation. Less is more. What does that mean? And I'll get into the specifics. Minimally invasive procedures as possible. Okay. And the fundamental execution of protocols. I'm going to come back a lot to the fundamental execution of protocols. All right. Resulting in overall long-term good or really bad results, right? But depending upon how we execute these procedures. And I always like to ask the question, just because we can, does that mean we should? And you'll see what that means later. So again, we always start in the beginning, right? Which is a little bit boring for people, quite honestly. But in the beginning, we have to figure out what we want in the end. And a lot of times we don't really take the time to do this, unfortunately. So we really have to look at what is the recipe for success long-term. And it's really, especially nowadays, what you see, just tons of courses and tons of presentations. It's all about hard and soft tissue. Because why? We need the foundation. If you don't have the foundation, you need to build it. It's really that simple. A house is only going to stand on a proper foundation. So unfortunately, we get to see cases like this all the time, and quite honestly, way too much. And if we have no bone, we have no soft tissue, right? So I'd really like to stop here for a second. We get conditioned to see cases like this, but I want to ask you, what if this was in your mouth? How would you feel, right? So this is the reality, in my opinion, what's most important, to always look at things from the patient's perspective, not just the workflow or the process or procedure. Look at what it's going to take to rebuild that patient, because you're making a lifetime change. And really the question becomes, how can we avoid these outcomes, right? So I'd like to go way back to the beginning. And I'm going to read this to you because this is really, really important. It's the biologic width definition as defined per Gargiulo in 1961. So the most significant factor in the long-term prognosis of restored tooth is a preservation. Let's see here, the screen is in the way. Let me try to minimize that. Can you minimize the, okay, wait a minute. Can you minimize the camera, please? Dr. Ashwin?
Yes, sir.
Can you minimize the picture in picture? Here, let me do it.
I think you have the option for that.
I'm gonna do that right there, and then I'm gonna do this right there. There we go. Now it's out of the way. The most significant factor in long-term prognosis of a restored tooth is a preservation of a healthy periodontal attachment. The best restorative margin is placed coronal to soft tissue. It is cleansable and can be maintained more easily. The term biologic width denotes the combined connective tissue epithelial attachment from the crest of the alveolar bone to the base of the gingival sulcus. This includes the width of supraalveolar connective tissue fibers and the junctional epithelium, which totals an average of 2.4 millimeters. During placement of restorative margins, an additional 1 to 2 millimeters of sound structure coronal to the epithelial attachment is needed. Hence, The minimum distance between the alveolar crest and the restorative margin should be 3 to 4 millimeters to allow a sulcus of approximately 1 millimeter. This can be determined radiographically. Impinging on this width by a restoration will trigger loss of bone and epithelial attachment. And interproximal encroachment leads to osseous crater that will be unmanageable from an oral hygiene standpoint, and thus a negative effect is the outcome. So we see what biologic width is. Again, it's that 3 millimeter zone of connective tissue, epithelial tissue, and free gingival margin, right? We know this, and yet it's impinged upon every day by laboratories who always get the shortest cuff height of abutment and just make it as emergent as possible, which is the wrong way to do it. When you're looking at aesthetics, you're looking at white and pink aesthetics, right? So what we have to ask ourselves is, can we consistently have this outcome? You know, we really, this is something that we want, but how can this be possible all the time? By case selection and treatment planning, which is something we emphasize and overemphasize. Take your time, plan the case correctly. And the implant system absolutely, most definitely influences the outcome. No doubt about it. Looking at tissue biotypes is another absolutely key factor that is sometimes overlooked. When you have thick gingiva, thick marginal bone, okay, that's the most ideal scenario you could have. When you have thin tissue, thick bone, you can do some connective tissue grafting, apically repositioned flaps, whatever the case may be. You need to get more kg. You have thick tissue but thin bone, you can do some guided bone regeneration. If you have thin bone and thin tissue, I say refer this case to Howie Gluckman. That's what I say, because this is something you want to avoid. It's not that easy of a case, right? So in the big picture, really, why should we implement planning and collaboration? We need to look at the mouth as a full arch structure, as an individual structure, I should say, and have our plan and work our plan. You can see here the diagnostic models are really the blueprints for what we're going to do and how we're going to build a house, let's call it. We have the foundation. How are we going to build a house? Every structure that's built has blueprints, all right? So we really need to take our time and do the proper planning for the superstructure that we're going to build. Diagnosis and treatment planning, please, please, please take your time in doing that. And there's lots of labs and diagnostic services that can help you do that as well. The very first thing you want to do is ascertain, obviously, a diagnostic CBCT and go from there as far as your planning process. So I'd like to emphasize and use a couple of slides here from Howie in how he builds the best foundation for patients. Now, very honored to have done courses with Dr. Gluckman in the United States. And now actually Howie is doing courses online. And there is nobody better, in my opinion, to take the online course, as you can see here. I'm pointing that out for him because there's nobody better that goes over the absolute fundamentals of execution and teaching you the right foundation to understand what the big picture is. And the big picture is really this: creating ideal soft tissue around implants. And how do you create the perfect soft tissue integration, right? So we see this around teeth. We see it constantly, all right? This is what we strive for. This is what this is a beautiful picture to most people, right? So this is really our goal. It's ideal hard and soft tissue, right? All right. So in my opinion, this is the most important slide of this whole presentation. All right. In order for implants to remain healthy, we need healthy bone of 2 to 4 millimeters on the outside of the implants. Notice I said 2 to 4, not the minimum. So minimum of 2, yes, absolutely. But shouldn't we strive for more and go for the maximum? 2 to 4 millimeters of bone on the outside of the implants. At least 2 to 3 millimeters of soft tissue to keep the bone healthy. And at least 2 to 3 millimeters of attached gingiva. Okay. And you can see here, again, we know that at least 2 millimeters of buccal bone is essential for long-term soft tissue stability. So if you don't have the tissue, you want to create it, right? So the word is minimum. Minimum is the key word, right? Shouldn't we want more if possible? Shouldn't we have an ideal scenario? Shouldn't we build that scenario if we don't have it? So again, the soft tissue barrier around implants is really, really key. So now let's go to a worst case scenario, in my opinion. Why do we cut all this nice keratinized gingiva away on all-on-X procedures? This is something that I ask doctors all the time who do these types of procedures. And, you know, where is our barrier? Where is our seal around those implants? This is the issue. So how do we create, how do we have stable bone, or rather a successful implant? How do we create that stable bone? So you want stable bone, you want a well-integrated Morse taper implant. Morse taper is not the same as conical, by the way, which is critical for long-term aesthetic stability. So Howie taught me something that's very, very important. He said, if you need an abutment removal tool, rather, if you have a Morse taper, then that means you need an abutment removal tool to remove that abutment, which some people don't like to deal with. But quite honestly, this is almost imperative. Why? That if you have that cold weld, that means you have that Morse taper connection. So first you have to remove the final screw from the implant/abutment connection, and you can clearly see that there are threads in the abutment as well, right? And you can always tell an abutment removal tool because it has threads in the middle of the shank. And then what you simply do is you continue turning until the driver bottoms out, and it simply lifts the abutment up. This is all it takes to remove the abutment from the connection. So when you have that cold weld effect, you have no micro movement. And as we know, micro movement is the silent killer of implants because of the micro gap and the micro pump effect, which we will talk about. So again, very honored to do courses with Howie Gluckman, and I've been to Cape Town, South Africa to his course, which is phenomenal. If you ever get the opportunity to travel there, I highly advise you go once we can travel. We think Howie is Superman, and quite literally, he thinks he is as well. So here's some fundamentals that I believe in, I'd like to share. Being as minimally invasive as possible, respecting the tissue you're working with, your finesse is key. Remember, slow is smooth, smooth is fast. Knowing different surgical techniques as well as microsurgical applications and confidence when implementing these procedures. Your tools, always use the proper tool for the job. And most importantly, don't be cheap. Get the right tools for the right jobs, invest in your success for your patients. All right. Here is a scenario showing obviously a lack of keratinized gingiva. So how do we create that keratinized gingiva around implants? Split thickness flap, and as well as apically repositioned flap is something that is really, really a beneficial procedure around implants that we should stop and do quite often, quite honestly. You can see your mucogingival junction, and let's see how Howie does this. I'm gonna show you a short video, and I'd like to show you the execution and the finesse that Howie uses in the application of these procedures. Very, very slow, very, very deliberate in his application of these procedures. Okay, and this is how, when I'm talking about finesse, this is exactly what I'm talking about. And one of the tricks that Howie does, by the way, each time is after each use of his 15C blade, he stops and gets a brand new one. So he uses about 15 to 20 blades in surgery. No doubt about it. You can see the gentle reflection of the tissue, getting that split thickness. And again, gentle, but deliberate procedures and application of these procedures. Again, soft tissue is key, and as well as the finesseful manipulation of that tissue. All right. This is a great video implementing a lot of different things because he's going to place some implants in just a second as well. Notice the dissection, the gentle dissection. All right. And when he makes his incisions, it's 2 millimeters away from the tooth and keeping that papillary area intact. So you have a stable area to suture your tooth. So again, anticipating what you're going to do next. Again, look at that. Again, very, very finesseful manipulation of the tissue. Just really, really, really a great video. There's so much going on at one time. Okay. You can see all that unattached area. And now, basically, once the procedure is done, now how he uses a guide. A guide to basically get his positioning, just marking the implant where it's supposed to be. All right. Going through the cortex. Now using a stopper drill. A stopper drill is very, very useful in not perforating or not going too deep. And then notice how he does. Now, how he's years and years and years of experience, but he stops and checks every time what he's doing. This is absolutely key, in my opinion. So you stop after each drill, put it back into the osteotomy, and you check what you just did to make sure you're still in alignment. And I see this mistake being done constantly. So take your time and check what you just did. See? Look at the alignment. Perfect. All right. And he's going nice and slow, nice and finesseful. He's about to place the implants. Puts a PRF membrane in there. Grabs the implant. Puts your handpiece adapter. You'll have the markings on there, 1, 2, 3, 4, and 5. To note how deep you are. So pressfully and placing the implant to depth, getting good stability, and then finishing with the ratchet. Nice and slow. Okay? Like I said before, slow is smooth, smooth is fast. Now that implant was torquing out. So what's he gonna do? He's gonna open up the crest and open up the cortex. He's not pushing the bone. He's not making it go too fast, and he's not over pressuring the bone at the crest, which is the most unfortunately delicate area, because cortical bone just does not like pressure. So you have to make that pathway for your neck to be able to bypass that area. Sometimes you have to open up the cortex slightly. Placing the implant to depth, finishing with the ratchet, finishing at the depth. Checking his alignment to ensure his proper angulation. ISQ readings, 82 and 83, as well as the other one, which is anything above 70. As you know, you can load. So therefore, the decision to make to put healing abutments on there with some chlorhexidine gel, just to ensure a clean connection. Then he uses, it's amazing, the 7/0 suture is so small. You really need your microscopes on to be able to suture with this stuff. But now implementing a apically repositioned flap in order to increase that keratinized gingiva, that band of keratinized gingiva below the height implant, below the implant connection. So obviously he's doing several procedures at one time here. Just beautifully executed. And I don't want to skip this part because most people, quite honestly, do their suturing as fast as possible. And quite honestly, suturing is probably one of the most important things you can do to ensure a good outcome. And again, take your time, suture properly, make sure your flap is stable, as Howie will show in just a second. Here's a good little trick, and he's actually suturing to the periosteum as well. So amazing work, nice and finesseful and delicate. Do not be in a rush when it comes to suturing. One of the most important things you can do properly. Okay. Again, look at the gentle manipulation of the tissue to ensure minimal trauma. Okay. Again, 7/0 sutures, amazing, just amazing. 7/0 nylon. Suturing to the periost. All aspects of the flap are ensured to be tacked down to make sure that all aspects of the flapping are nice and tight. All right. Almost done here. I like this. Confirming periosteal engagement. Watch what he does here. So he's going to go deep to make sure his whole flap is nice and stable. So he goes deep to the periost, and then watch what he does here. He pulls on that to ensure that you're tacked down and your whole flap is stable. This is really, really an important aspect that we shouldn't skip, and make sure that that procedure is done. Done. All right, now you see the final big picture. It's just amazing. Beautiful, beautiful, beautiful. So I'm going to quickly kind of run through this now because that video took a little bit of time. The triangle of bone, this is by Dr. Scott Gans. We have to really, again, plan our plan and then work our plan. Is there enough bone? What type of tissue do we have? Etc. Notice you see the lip is away from the soft tissue, the buccal soft tissue area, and that's done with the cotton roll technique. This is something I don't see done hardly at all, and it's honestly one of the most important things you can do to be able to dissect and differentiate your soft tissues. What's the plan? What's the big plan? What type of implant? What type of abutment, et cetera, et cetera, et cetera. So the triangle of bone is really key. Again, Dr. Scott Gans, throughout his years of implementing digital dentistry, is just a pioneer. Don't forget cotton roll technique. So let's look at this case right here. Again, implants being placed, proper angulation, et cetera, all the planning process that needs to be done. All right. We'll get back to that in just a second. Now, what we're trying to do is really look at how can we stack the cards in our favor also with the implant. So you have an implant design that has really phenomenal primary stability. You have the biologic neck, you have platform switching, but the whole goal and what we're trying to do is create a bone seal around the implant. And you almost want a bone overgrowth, if you will, around the implant. And as throughout history we know implants with micro movement, micro gap, etc., just does not maintain that. These type of implants result in beautiful hard and soft tissue. And again, this is really our goal. So this is why the implant definitely influences the outcome. So when you do have bone overgrowth, please do not go and cut it all away because it's in your way. No, 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 no. I see this all the time. Get the bone profiler. And they do come in at 50 RPM, by the way. They do come in different sizes, small, medium, and large. It's really that simple. So small, 4, 5, and 6 is medium, and 7 is large for molars. So if you do have bone overgrowth, it is to be profiled away, not cut away with a round burr, as I see happen a lot. So the big picture perspective of now that we have the implant designed to hold the bone, etc., what is the big picture of the restorative planning? Now, my brother from Tunisia, Ashraf Souaya, did this case, and he did this actual case freehand. And I hope you can appreciate the slight angles and angle differences that you can see, and the vision of what the big picture is, and how you can literally see what the outcome is relative to the restorative design, restorative plan. Remember the blueprints. This is the outcome of that. And if you can clearly see where the surgical or the central fossa was of the implants, and notice the slight, again, the angle differences. This is very, very, very difficult to to do that without having a guide. So just amazing case from Ashraf. And symmetry of the arch is key, but individuality of each tooth is fundamental in the symmetrical goal. Okay, so you really have to look at this and go, we want to make each tooth as beautiful as we can, because as you know, they all work in one. They work in unity. So it is it's unified in the same goal. So full arch perspective, not quadrant perspective. All right. Again, implant definitely influences that. And again, I go back to the perspective of each time you use a drill, take it out of your handpiece and put it right back into your osteotomy every time, and check your angulation to ensure your path is staying where it's supposed to be. Okay. Hard work becomes easy when your work becomes your play. And it is really passion that why we do what we do. So what does the connection say? I invite you to look at Zipprich's work that's been done over years, and it's called Zipprich Micro-Movements on Implant Abutment Interfaces, Part 1 and Part 2. You can just Google this. He's a prosthodontist, and you can clearly see what his work has showed us in the evidence of the microgap, and you can see here what happens when you have even an internal connected implant under function and under load. They definitely have micro movements. So this micro movement becomes micro pump, because that micro pump effect that opens up and it gets bacterial soup into the implant. This is why micro movement is the silent killer of implants. Micro movement back and forth creates a pump effect that draws in and pumps out bacteria from inside the body of the implant when in function. This irritates surrounding tissue and creates recession of bone along the implant abutment connection. And most importantly, it stinks like hell. If you've ever noticed where you take an abutment off and it stinks, guess what? That's a problem, right? So we really have to balance the different connections in history that we've seen that work. Some attributes work, some attributes didn't work. And a lot of, unfortunately, a lot of these implants are still in use today. And I scratch my head as to why. So we know today now with obviously with the ultimate outcome being aesthetics, that we want a combination connection, but deep internal hex, deep Morse taper, platform switch connection, and bone level implant. And obviously having the added benefit of the threads for primary stability really doesn't hurt. So if we look at history, all the different types of what I call widgets or wadgets, there's so many you can shake a stick at. The reality of the implant design, though, is the final drill is always typically about 0.7 millimeters smaller than the outside diameter of the thread. So if we keep going throughout this whole slide, now what happens as the drill gets bigger? You're really taking valuable bone away, all right? So how do you look at that and sit there and go, should we be following this protocol, or should we try to look at it from a bone density perspective, and also the type of implant that facilitates the type of surgery that you're looking at? Now on the right, you clearly see an implant that's a bigger piece of titanium in the middle with smaller threads. But you know, sure, it'll work if you have the ridge that's big enough. But obviously on the left, you see a wider pitched thread with a smaller core size, but it's still strong for stability. Now we talk about platform switching. We really, when we're talking about platform switching, we're implementing the aspect of medialization of the abutment to the implant platform width. Also, I'm going to read this quickly. From an engineering perspective, it is widely accepted that the bone loss around implant's crest module is multidisciplinary in nature. These factors are related to the implant collar design. And when we look at different types of implants throughout history, you have divergent, you have parallel, and you have convergent. Convergent definitely, the convergent shape module of a sloping shoulder, and that's really key. The sloping shoulder can be considered as the ideal implant design for homogeneous occlusal force distribution and bone loss prevention. So when you have no threads at the very, very top, but you still have that sloping shoulder, that relieves a lot of the pressure from the neck as well. But you have, again, threads that really give you phenomenal primary stability. As you can see here, definitely a biologically driven implant. This is called the Any Ridge. And a lot of people have, I've heard on this platform, been talking about the 5-thread stability guideline. With this implant, you really need 2 threads, and that's really it. And why do you only need 2 threads? As you can see, this is a corkscrew type thread. This is really the secret to this system and how it works so fundamentally with what you're trying to achieve. That corkscrew type thread is just an amazing thread that gives you absolutely amazing primary stability, which you can clearly see here in this quick video. When it goes in, again, that corkscrew type thread engages immediately and gives you that primary stability. All right? But at the same time, look what it's doing to the trabeculate bone underneath. You're engaging that, and it's going in almost without force, quite honestly. But you attain better primary stability because of the surface area. Now, one of the things we talk about nowadays, especially, is we actually would like to go 2 millimeters below the height of bone. So what I like to tell people is, if you're going to place a 10, prep to 8.5. If you're going to place a 10 millimeter length implant, prep to 11.5. Obviously, if you have the room, this gives you the flexibility to place your implant collar at the proper height. Okay, that primary stability is key in attaining that ideal outcome, because then even if you had a buccal defect, as you clearly saw there, you can graft around that. So really what I'd like to emphasize with this type of implant design, and there are other types of implant designs that do the same thing as this without the thread design though, is the preservation and thickening of the biologic width in kg and the preservation of the crest of bone. That's really, really key. And you do have phenomenal outcome. Now, something that's overlooked consistently, and I'd like to emphasize again throughout a historical perspective, is the thickness or the width of the threads themselves. That's absolutely key. Why? Because you have a bigger, let's call it a bone notch in between each thread, which maintains your blood supply, and you actually get better angiogenesis. So if we look at history and what we see here, people love the aspect of the old, what they call tissue level implants. And they say, well, I just always maintain my bone with that. Well, why? Because your restorative margin was above, as per Gargiulo, was above the height of crest of bone, either 2.8 or 1.8 millimeters. But then look at the thread width. The thread width was key. So this is the same thing on the innie ridge. So let's talk about an osteotomy.
A drill intrudes and destroys the naturally sculpted bone. Blood vessels are torn and a major defect is created, quickly filling with blood. The titanium implant is inserted where the tooth was previously lost. At first, the only force holding the implant in place is mechanical friction. This is called primary implant stability. Osseointegration, or secondary implant stability, requires a highly complex sequence of additional biodynamic processes. This is facilitated by finely tuned communication between the main actors of wound healing, the cells.
So again, are we making our osteotomies in the right position? And another little trick I like to always say is, you want to start lingual from where your ideal position is going to be. Because if you're doing a freehand case, if you start slightly lingual, you're naturally going to drift to the buccal. So you should start your osteotomy not where you want to be, slightly lingual to that, and then you will naturally drift to the buccal because the buccal bone is softer, especially with your body mechanics and your hand movement. So you can clearly see when we create an osteotomy, we really want that nice, healthy bleeding of the bone, okay? That gives us our foundation. Fibrin clot is formed. We place your implant integrates. We build our soft tissue again, emphasizing Ashraf's work here. And how can we build this beautiful soft tissue? And this is by utilizing the right size healing abutments, 4 small, 5, 6 or medium, 7, 8, and 10 are large. Really, really, really that simple. Okay, why do we see things like this in today's day and age still? So we cannot solve our problems with the same thinking that we used when we created them, right? So I really, again, go over fundamental execution of things and are we doing things the right way? Guidelines that we know will protect us, our implant positioning as far as our spacing goes, mesiodistally, apical coronally, We know all these rules. We have all these rules. So let's apply all these rules to give us the best long-term outcome for the patient. And let's not compromise these rules, okay? Really try to stay within the parameters of the spacing that we need, obviously, for all applications. We are what we repeatedly do. Therefore, excellence then is not an act, but a habit. So here's a beautiful case, okay? What I mean by that is beautiful is, look at this. Look at how the outcome is, right? Right through the buccal. Now, how do we fix it? Remove that, okay? We redirect the osteotomy with typically the Versa burrs, osteodensification burrs, which I'll talk about a little bit later. Primary stability, look at that, is 79, even in a partial osteotomy. ISQ, that is xenograft, to be able to preserve that and recreate that buccal area over the long term, and then making sure our suture lines are done properly and our margins are correct. All right, again, we see cases like this all the time. So what I like to emphasize is, please don't follow just a protocol that the company gives you. Don't follow the protocol. Look at what's ideal you have to look at really your own and have the feel of the bone itself. You have to consider the bone density, the ridge width, the soft tissue type, available vertical bone, alignment of final prosthetics, central fossa, everything that we know nowadays that we should be doing, okay? The type of implant design facilitates the drilling protocol for sure. You can clearly see the width of the threads and how, again, you have a smaller core yet wider thread engagement with more blood supply around that versus a bigger piece of titanium on the right, taking more bone away. So really what's most important is, again, reading the proper bone density, D1, D2, D3, D4. We all know sometimes there is even D5. So here is showing a 5.5 millimeter implant going into a 3.3 osteotomy. Why? Because it's D4 / even D5. Okay, 60 Newton centimeters. Now I'm going to show you a trick at the very end, because that torque value is a little high at finishing at the end, because 60 is just a little bit high. You want to be around typically not above 50. That's your goal. So when the implant is placed to depth, what you do is you place it to depth, and then you simply back the torque off a quarter or a half a turn to relieve that pressure at the crest. It's very, very, very important for pressure necrosis issues. Very, very important. Okay, so again, looking at bone density and the hollowness or fullness of the mandible or maxilla is all in the planning process. Again, we have to look at these things in order to facilitate the right protocol. And again, taking into consideration the proper bone width, etc., as well as, again, should we be considering osteodensification? So your bone quality, and as well as your protocols that you should be following, are really not something that are going to be consistent on every patient, as well as even every area of the mouth. It's all, one patient can have super hard bone on one side and on the other side completely soft bone. So it just really, really, really depends. So you should be cognizant of that. Again, this you can see one of the older divergent type implants that engage the cortex area. And typically what happened is we saw bone dieback or cupping around the cortex. Why? Because it's putting too much pressure on that cortex. The cortex does not like pressure, as you can see here. Okay, beautiful, exact case of dieback. All right. And so when you have a biologic neck and lower thread engagement with high thread stability from the cancellous bone, that relieves pressure on the cortex itself. So you want to be, and you want to place that implant 2 millimeters below the height of the bone, not 1. This is going to give you a better outcome. Now, this is the new Bible on crestal bone preservation. It is by Thomas Linkevichus. He has the zero bone loss concepts, and you can actually take his course online as well. We are proud to sponsor his courses in North America, and we look very much forward to 2021, that's for sure. So again, saving precious bone is the key. So again, that is living tissue. Now, now we have, as far as, again, back to biology, what type of implants do we have to facilitate, especially for molars, a stronger implant, but yet smaller thread, but yet still type of threads that give you phenomenal engagement. So you have the, what we call wide core implants now as well, instead of just the 3.3 and the 4.8 as we've always had. You clearly let's see here. Where was I? I'm obviously running late now, so I should probably just cut some, yeah?
You can go ahead, sir.
All right. I'll cut some out quickly. All right, I'm gonna keep you up here. Sorry about that. I have no idea what happened. It just quit. We were talking about wide core implants, and I just want to show you a clinical case of the 3.8 and the 3.3 old style versus new style. Again, proper height of bone, beautifully done, papilla preservation type incisions. Now you can clearly see the wider core, stronger core, molar type implants for the molars, as well as the always Ashraf does a beautiful job of, when you suturing this up, you want to start with a small healing abutment if you have a healed site. Why? Because that way you have enough space for the tissue to mature, and then you go to the bigger size healing abutment once the tissue matures fully. So that way you're not squeezing the tissues too much. This is a case by Dr. Linkevichus showing custom tissue formers as well, which is beautiful. And again, you can see the link for the zero bone loss concepts courses that he's having around the world that are really, that Megagen is honored to help facilitate. All right, what about bone harvesting for autogenous bone? All right, quickly you can see these are Automax burrs. So instead of what I say, getting rid of all this bone, why not save it? Why not reutilize it? Especially if you have a defect in the buccal area. Oops. Sorry. Let's see here. Yep. Okay. I'm just going to skip that. So the old versus new mentality is soft tissue, everything we need to prepare and preserve our foundation. This is what we strive for. This is what we try to do every day. And this is what our goal should be. Also in the prosthetics as well. How do we preserve all that tissue in the prosthetic area? By having a smaller interface and the platform switching. As you can see here again by Dr. Linkevichus, you see remodeling when the emergence starts too fast versus a cylindrical type connection where you see an overgrowth of bone. So I say zero bone loss concepts, join the movement. It's very, very key in highlighting all the critical protocols and procedures. So again, zero bone loss concepts. A little bit of a final note for the prosthetic procedure is use a full arch tray, please. Laboratories will thank you for this. When you're using a full arch tray versus a triple tray or any of the quadrant trays, which in my opinion should be thrown away. Use full arch trays for everything. Minimally invasive drilling. Okay, what are we talking about? Osteodensification. I will end with this. Osteodensification. What is osteodensification? We're densifying the bone through autocompaction or autografting. All right. So in there again, instead of taking the bone away, we're preserving it. All right. So what is osteodensification? It's really basically the bone compressed laterally with a constant rotating drill that is shaped in such a way that creates that energy that you need to not only preserve the bone, but preserve the bone and expand the bone. But when you're doing crestal sinus lifts, it's really amazing because it creates that mushroom effect, if you will, with your membrane. And you'll see what I'm talking about in just a second. So here you can see a normal drill. And here you can see on the left, a osteodensification densibore. Now let's look at that side by side, see what happens. You can see in reverse, the normal drill, and this just in a viscous gel creates no energy around that. It's just cutting away, right? Whereas, look at the VersaBurr and what it's doing. So you look at that, and when you use the VersaBurr, especially in the crestal sinus process, it's really amazing and actually gives you that exact scenario. So if you want to judge the bone and be better at judging the bone and what type of bone you're in, you can actually use a VersaBurr, typically about the 2.5 millimeter drill, and use it at a very slow RPM, 50 Newton centimeters, 50 RPM, and judge the bone. And let's see, again, by Dr. Isaac Tao, let's see a really nice result using the Versa, and then I am done. Again, that biologic driven osteotomy. What are we doing? We're preserving that bone, we're not taking it away. 800 RPM in, like, if you have D2 bone, I actually like to go about 600 RPM, or even slower in D3, D4 bone. You don't need that much speed. It actually works a little bit better when you go a little bit slower in softer bone, in my opinion. So you can see you're getting resistance from the bone, but it's compacting sideways. And again, this is most importantly reverse drilling protocol. By the way, the VersaBurr is cut very nicely in the forward position, very, very nicely. But they're more known for the reverse autocompaction aspect. So let's say you're utilizing your drill and you come to a little bit of a hard area, you just can't seem to get by. So you would stop, move your drill in the forward position quickly, get past that little dense area, and then go back to the reverse drilling. So you use your Versa drill in both the reverse as well as forward direction. The implant going in. Nicely getting really, really good stability. Again, implant's almost to depth. Now, how do we finish it? By hand with your torque one. And again, you can, once you place that, you can back that pressure off just a little bit. If you so choose, a quarter of a turn. That's a good little trick to use. Nice depth on that. Implant, typically, again, 2 millimeters below the height of the bone, not 1. Minimal trauma to the tissue, close that area up. ETFE suture. Dr. Tao has a lot of experience with the VersaBurrs, as he was one of the pioneers and started clinically testing it. All right, so I'd like to end this whole thing with some parting words from Yanni. So I'd like to say thank you very much. The MegaGen message that we have at our factory is build a bigger table rather than higher walls. Be part of a bigger game. So 100 years of MegaGen, thank you very much. And thank you, DentistChannel.Online, for this. This has been an honor. Thank you very much. Sorry about the technical glitch. I don't know what happened.
So we have our first question from Tanushree. What are your views on splinting multiple adjacent implants? Is it required in case of immediate loading prosthesis?
Are we talking the final prosthesis or the provisional?
Prosthesis, splinting multiple adjacent implants.
It really depends back to the bone. If we go back to Carl Misch's book, Contemporary Implant Dentistry, he's a huge advocate of splinting. You have to do it, however, in such a way that you have the proper sleuth ways for proper hygiene. Is it ideal? No. Do patients like it? No. Is it necessary sometimes? Absolutely. So we have to take everything into consideration, and absolutely, in some instances, most definitely splint, no doubt about it. But again, all relative to the end result and the patient expectations.
Yes, sir. Thank you for your answer. So we'll move on with the next question from Supriya. What is the reason for saucerization of crestal bone?
Cool. That's multifactorial. There's so many issues. It could be how aggressive you are with your osteotomy. Typically, in my experience and what I've seen over the years, it has absolutely been the implant connection, no doubt. And this happens over time. Everybody says, well, especially with a basic or what I call a universal internal hex, they say, well, look at the beautiful bone in the beginning, but now show me that bone in 3 years. You always see saucerization. Why? Because of the micro movement, the micro gap, the micro pump effect, and all that, everything we just talked about. So there is not one particular aspect that we can say, this is the reason, but it is an accumulation of reasons. So yeah, that's my best answer.
Yes, sir. Thank you so much for answering that question. So further to move on, sir, how do you see the scope for dental implants in the post-COVID era?
Oof. It's funny. I have a lot of, obviously this is my business, this is what I do. I have a lot of clients who they are so busy. It's amazing. What I hope to see, what I absolutely, if I could draw a utopian world, I would hope to see sterile technique being utilized on every surgical application. And in today's day and age, it's not. It's a matter of fact, less than probably 10%. So post-COVID, you have to understand that we have to do the proper sterile technique in order to get better outcomes for obviously secondary infection, et cetera, et cetera. So.
Yes, sir. Definitely things have changed now, maybe with respect to the personal protection or other aspects of the dental economics. So thank you for answering that question, sir. So to move on, can we place any ridge implants in any patient? So what are the peculiar factors to be considered?
There you are. I lost you for a second. I was like, I couldn't find you. Can we place any ridge implants in any ridge? Yes, absolutely. The factors, most definitely, again, ascertaining the bone density. What is your plan? How to best create your osteotomy? As I tried to say, a lot of colleagues that I have still now typically undersize their osteotomy in order to get better stability. Why? Because of the implant design that they utilize. But this is not aiding them. So in the final outcome anyway. So what's nice about the AnyRidge system, most definitely, forget about that I'm the vice president of the company, is the universal aspect of the connection of the prosthetics. This makes your prosthetic facilitation so much easier because of stock issues. Everything works as far as this is why I emphasize your small, medium, and large abutments for your healing abutments. It is the same thing in the prosthetic abutments, whether they're the custom tie blanks that whatever you need, the zirconia, the tie gens themselves. It just depends on what your final game plan is, but there is every prosthetic option out there. So most definitely the answer is yes, but again, there are variables to that.
Yes, sir. Thank you so much. So what is your take on corticobasal region, sir? Or how do we proceed with that? I mean, regarding the osteotomy.
Say that again, I'm sorry.
What is your take on one-piece basal implants? How do we go with the osteotomy?
One-piece?
Basal implants, corticobasal implants.
They're not my favorite. They're not my favorite. I'll just be honest. They're not my favorite. Since I'll use the word prosthetically trained, everything is about retrievability as well as being able to maintain. So I much prefer the two-stage approach. Why? And obviously screw retained. Because if something goes wrong, you can always take it off, fix it, put it back. If it's a one piece, you're stuck with that.
Yes.
So it's, for me, I like to look at it from simple perspectives, like a car. You can take your car in and get fixed. You can take the tire off. You can fix it, right? You can do whatever you need to do.
Yes.
But with a one-piece implant, you're stuck. You're stuck with it,
Yes.
right?
Yes, I got it. So to move on, sir, what would be the ideal suture material that you would prefer?
I'm sorry, one more time.
Regarding the suture material, sutures.
Sutures. My two most favorite sutures are definitely PTFE and nylon. No doubt about it.
Yes, sir. So do we go with the absorbable ones?
Do we go with, I'm sorry?
Absorbable ones or not resorbable?
No, not resorbable.
Yeah.
Not resorbable. You want to control your suture lines.
Yes.
Absolutely. So you want to do. Now, here's the funny thing. I see doctors sometimes, and my clients say, well, I'll see you in 3 weeks after the surgery. And that's a mistake. You want to see the patient in 1 week. Why?
Yeah.
Just to quickly check. It's not good that you're going to do anything. Just to quickly check how everything is proceeding, so you can keep an eye on everything. Yeah. But typically suture removal is in between 2 and 3 weeks, depending upon the suture area, the sutured area.
Yes. So what's your take on doctors who claim that they can provide no teeth to fixed teeth in 72 hours? So if that is the case, then why are implantologists still practicing conventional implantology?
Don't ask me that if you don't want the truth. Is it possible? Yes. Is it something that we should be marketing prevalently? In my opinion, absolutely not. As I said, one of the biggest things that we talk about in this hybrid bridge delivery, yes, they get the provisional and they leave with teeth, but now they have to have the final, which is typically acrylic, same acrylic. Now what happens with acrylic, and when it's in the mouth consistently, it gathers stain, it gathers smell, it becomes a hygiene nightmare. Yeah. So how do you maintain this? On top of that, you're cut away all the keratinized gingiva after the procedure is done. So where's our seal? There is none.
Yes.
So no, it's not my favorite procedure at all. No, at all. So
yes, we need to look for the longevity and also to maintain
longevity. Put yourself in the patient's shoes. What would you want? Don't focus on the money and that you're going to get immediately. Focus on the long term. Absolutely.
Yeah, because an implant patient is for the lifetime.
Absolutely.
Yes.
Yeah. There's an old saying, when you're getting to implants, you're married to your patients, and absolutely you are. And a lot of implant patients disappear after they're restored, and they should be maintained once a year for their occlusal checks. Absolutely, just like you maintain your car, no difference.
Yes. And then the next question is on heat generation. So while performing osteotomy, obviously there is some heat generation. So what are the methods that we can use to reduce that? Of course, we have the.
Excellent question. Excellent question. I'm sorry, you were saying, of course, we have the.
Yes, sir. We have different methods, like inbuilt, there will be saline water that is dripping in. So all those things are there, but still, what is your take on the heat generation during osteotomy?
The easiest thing to do, it's very, very simple. Slow your RPM down. That's it. Slow your RPM down. You do not need, if you're in soft bone, why do you need 1,000 RPM? Why do you need 2,000 RPM? Yeah. If you're in D1 bone, obviously you need a little bit more, you need a little faster RPM, no doubt about it, because it's denser. But if you're in softer bone, simply slow your RPM down and make sure you have copious irrigation. Depending upon the motor type that you have, the little notch that irrigates onto the drill, make sure that it's hitting the actual drill itself, because a lot of times it's going sideways. So you want to make sure that that little nozzle is hitting the drill itself, and you want to use nice, smooth pumping action, 1, 2, 3, out, 1, 2, 3, instead of just laying on the burr and not letting all the particles come out, as well as clean the osteotomy out itself. Now, densification is a completely different process because you're densifying the bone sideways.
Yes.
Right.
Yes, sir, definitely. When we have used in our clinical practice, the osteo densification, the Versa birth, it has given us a really good results.
Excellent.
Yeah.
Excellent.
Yes. And then I have a final, it's $1 million question. So what according to you is the best implant?
Any ridge, baby, any ridge. No doubt about it. No doubt about it. Yeah. It's amazing. Once you place an any ridge, it's almost like you can't. You're addicted to crack. The primary stability that you achieve is just amazing, and that predictability and that's the key word. That predictability that comes from primary stability is key, and it's a very good feeling to have.
Yes. Okay, sir, we have a couple of more questions. Shall I proceed?
Yeah, please.
Yeah. Okay. Morse taper is also a very important aspect that you mentioned. So what is the ideal Morse taper connection? So why are not many companies not working on this discipline?
Exactly. There is a 1.5 connection out there, which is the definition of a true Morse taper. It is difficult to work with because every little thing, it sticks in place. The 5-degree Morse taper, let me go back in history. There was Ankylos on the market, which was 5.7 degree. And it definitely had a nice sticking Morse taper effect. Great bone preservation, but the neck was very, very skinny. So a lot of the necks used to fracture a lot. So the 5-degree Morse taper does give you that flexibility and security of the Morse taper absolutely doing that cold weld effect, but yet having the variability, because you need tolerance. You need slight tolerance in order for the parts, as you know, to go in and out. A 1.5 is very, very tight, which is mainly used with a tapping effect. But the variance of the 5 degrees is very nice to have. Are there other, typically, as Howie says, and again, I love me some Howie, the 5.7 and smaller Morse tapers have that sticking effect. When you go to 8 degree, you can remove the screw and just take the abutment right out. It doesn't stick in place. This is the determining factor. If the abutment sticks in place, you have a Morse taper.
Yes, sir. Thank you so much for giving that perspective. Sir, India is a market which is price sensitive. So how can we convince our patients for an expensive implants like any ridge that you mentioned?
Very, very, very good question. I was also what we call a treatment coordinator here in the United States and talking with patients about it. It is really, and many people have done studies on the acceptance of implants from the patient perspective. Here's a good question to turn that question around. You see people who may not be able to afford a Mercedes, but why do they have it? Right?
Yes.
It's perceived value. And if you don't create that perceived value, how can they ever accept it?
Yes.
It's again, really that simple. So
yeah.
the treatment coordinator / doctor, whoever it may be, should create that perceived value, because this is for the life of the patient. As we get older and so forth, what is there to do? We all enjoy going out to a nice dinner with the family and enjoying the personal time. So eating, if you got to take your denture out, is not any fun. So quality of life is key.
Yes. So it lies in the hands of clinician to convince the patient by good educational methods, maybe showing a previous success stories and also the testimonials of previous patients. Maybe that also will help.
And that's key, what you just said right there. Absolutely. If you have some patients that have had treatment and are absolutely, over the moon, have that patient as a testimonial person where your patient X can call patient Y and go, hey, what do you think about this? You know what I mean? So it absolutely helps tremendously.
Yes. So we really need to work on those patients who are loyal to us, and it was a successful treatment in them. So maybe having their reviews in our websites or our social media might help other patients as well.
No doubt about it.
Yes. So there's one more question, sir. So you mentioned that abutment stings when removed. So what sign is this? Is it leading to peri-implantitis or something?
Very good. It's actually the accumulation of the bacterial, what we call that bacterial soup. So when you have that pumping effect every day, it builds up a film inside the implant. And again, it stinks so bad that when you remove that, automatically remove that abutment, and we talked about what a passive internal hex or an external hex or something that doesn't stick into place. And as I said, conical is definitely different than Morse taper. Morse taper sticks, a conical doesn't. You still have the offsetting angles with a conical. It seals, but it doesn't stick. So it doesn't completely do away with the micro movement. What was I going to say? That film, as soon as you remove that and everything stinks inside of there, it obviously then relates back to peri-implantitis and how it can definitely affect the surrounding structure, no doubt.
Yes. So I do think that maybe we need to educate patients more on maintenance of implants as well, because it's not just about drilling and placing the implants and sending them back. Maybe we need to think more on maintenance aspect as well, to educate them to use maybe some interdental aids or something of that sort to clean the area.
Correct.
What's your take on that?
Correct. Absolutely. No doubt about it.
Yes.
The reality is, are they going to do it?
Yes.
No.
So maintenance is also the key part that is very important.
This is why they come to you to the dentist to begin with, because they have a toothbrush allergy.
Yes. Yes. I get it. So one more question. So any ridge, it's for all patients of for all bone types. So what's your say on that?
Yep, absolutely. No doubt about it. From small thread to the wide thread, D1, D2, D3, D4. But now, as I tried to emphasize in the molar area, which is a completely different animal, you have your different core sizes. So if you have a nice resorbed ridge already, which typically the resorption pattern is on the buccal that comes this way, and you have a smaller width of bone or band of bone, then you can even have the 3.8 core, which is a smaller core, but yet still strong enough to maintain a molar. So you do have biologic options of 3.8, 4, and 4.3, as well as the one that's always been, which is 4.8, which is for big, huge ridges. But it's a really nice option to have the 3.8, especially for first molars on females, as an example. 4.5 with the 3.8 core is perfect for a molar.
Yes.